Good afternoon, everybody. Thank you for joining us for the Fetal Care Chat by the Fetal Health Foundation. My name is Lonnie Somers, and I am joined today by Dr. Sherzana Sundergi, who is is Director of Fetal Cardiology and Echocardiography at the University of California, Davis, and is also an Associate Professor in the Division of Pediatric Cardiology. Thank you, Dr. Sundergi, for being with us today.
Thank you for letting me be here.
So I want you to go a little bit more into kind of your background, because it's pretty fascinating. We were just talking about how you were from Canada and left the cold there. But with our Fetal Care Chats, for those of you joining us, Fetal Health Foundation is there to help families and as an advocate and help research and support families and also the medical community with factual information when they're going through a fetal anomaly or fetal syndrome. And one of the things that we have certainly realized is that when you are high risk, a lot more tests tend to be ordered and imagery and so forth, such as fetal echoing and echocardiograms and so forth. And we thought it was very important because I don't think a lot of people understand what is being looked at and so forth. So we thought this would be a great topic to have out there for everybody to be able to ask questions and answer and get some answers in from the experts themselves as we look to that. But first, Dr. Sundergi, again, thank you so much for joining us, and tell us a little about your path to getting into cardiology.
Yeah. So as we mentioned, I was born and raised in Canada, and I had a great opportunity, and I ended up pursuing my undergraduate degree at Yale. After that, I went to Dartmouth Medical School, and then I had enough of the cold, I guess. Actually, I went to Children's Hospital of Philadelphia to complete my pediatric residency, and then I came over to California to the University of San Francisco to complete my cardiology training in pediatric cardiology. And then I stayed an additional year to do advanced training, and a part of that training was in fetal echocardiography. And then my first faculty position has been at UC Davis, and I've loved it so much I've never left. And I am the director of fetal cardiology here at UC Davis.
That's right. And we should mention a little bit that you have a lot of honors and awards, including membership into the Alpha Omega Alpha Honor Society, as well as the Gold National Humanism and Medicine Society, and being named a top doctor in Sacramento every year that you've been in practice, which obviously I can already tell you have a very personable touch to things. So I'm sure there is no doubt about, besides your expertise, having that patient connection, which kind of gets us into a lot of high risk pregnancies because it's very high and stressful. But I also found it interesting is that not only you are an expert in fetal cardiology, but also all the way up through adults. Tell us kind of briefly, why do you feel that's important, allows you to be better in what you practice?
Yeah, so part of the pediatric cardiology training is that you learn different cardiology than adult cardiology. These are children that are born with congenital heart defects. So the typical 4-chamber heart isn't necessarily there. And a lot of times, since our children that are born with congenital heart disease require so much care, so many surgeries, they are very attached to their pediatric cardiologist, and we've actually been trained to follow them over time. There's a new fellowship that's kind of developed in the past decade or so called adult congenital, where there's a combination of pediatric cardiologists and adult cardiologists who are trying to help with that transition of patients that are born with congenital heart disease from into adulthood. But because adult cardiology training doesn't necessarily focus on congenital heart disease, a lot of pediatric cardiologists will follow their patients through adulthood.
That's very interesting. Great. So when someone is diagnosed with during pregnancy a fetal condition that might affect the heart, or they want to look to see how the heart's being affected by that, what is kind of the first thing? Because obviously the next thing is an ultrasound or doing an echocardiogram. What do you kind of tell us about what type of things would look like to necessitate that exam, and then what type of things are you typically looking for?
Yeah, so a majority of the referrals for a fetal echocardiogram happen because during the normal anatomy scan, they notice something abnormal. So just to give a little bit of history, prior to 2013, there was no rules in regards to what needed to be noticed on an ultrasound when they're scanning the heart. So it was usually just the 4 chambers of the heart. That will only diagnose up to 60% of all congenital heart defects. So in 2013 and 2014, the American Heart Association, as well as SUOG, put together a big guideline that said that during a normal anatomy scan, which most women get during that 18 to 20 week time, they should be looking at the 4 chambers of the heart, the outflow tracts, which are should be crossing in something called a 3-vessel view. If this is noticed to be abnormal, they should be referred for a fetal echocardiogram. And what a fetal echocardiogram is, it's a detailed assessment of the fetal heart using ultrasound. So we just look at the heart in much more detail than they can in normal anatomy scans. So this is typically performed by a sonographer who's been trained in pediatric cardiology and done additional training in fetal cardiology. And then images are interpreted by a physician who's been subspecialty trained in pediatrics, then pediatric cardiology, then advanced imaging, and then fetal physiology. Here at UC Davis, what we do, our fetal cardiologists will immediately go and share the results with the family just to ease the stress of the test, as well as counsel the family accordingly in regards to the results. In a fetal echo, we actually obtain a lot of information. So we can determine the structure of the heart, so determining if there's any congenital heart disease. Also the function or the squeeze of the heart to determine if there's any cardiomyopathy or ventricular dysfunction, which can lead to long-term morbidity and mortality for our fetuses. And then also fetal echo will give us an indication of the rhythm of the fetal heart to determine if there's an arrhythmia. Sometimes that can be as typical and normal as an irregular heartbeat, which can happen frequently in the 3rd trimester, or if there's a tachycardia, which is a very high, fast heart rate, or bradycardia, which is a slow heart rate. Those usually need to be intervened on with medical therapy that's given to mom. And all of this information is very important to obtain. One, it helps the families so they can make decisions in regards to their pregnancy. It can also help us as medical providers prepare the family in regards to the prognosis of the congenital heart disease and the arrhythmia affecting our child. For certain congenital heart diseases and defects, we have fetal cardiac interventions that we can do to alter the cardiac physiology and then potentially the long-term prognosis of children. So for example, there's aortic stenosis, and what this is, or critical aortic stenosis. And this is when the aortic valve is too small on the left side of the heart, so it doesn't allow adequate flow through the left side of the heart. So we can perform a fetal aortic valvuloplasty in certain cases. And so what happens in this intervention is we insert a needle through the left ventricular apex through the aortic valve, and then we put a very specialized balloon across that valve. We inflate it and deflate it, and hopefully we'll have improved flow over the valve. And there have been several studies now that have shown that this can actually help prevent the development of something called hypoplastic left heart syndrome and potentially allow for biventricular repair or 2-ventricle repair after birth. And then the last thing why I think fetal echo is very important is that it helps us determine the most appropriate mode of delivery or where to deliver for families. We want mom and baby to get the best care possible, and we want them to get that care and be delivered in an institution where that can be provided, especially in our kids with critical congenital heart disease, where they may need an intervention immediately after birth. So UC Davis is a tertiary referral system or hospital in the Central Valley here in California, where we have pediatric cardiologists available at all times of the day. And we have our pediatric cardiothoracic surgeons who can provide care for mom and baby immediately after birth. And there have been several studies that have actually shown that the importance of prenatal cardiac diagnosis, especially in our kids with critical congenital heart disease, and that with prenatal diagnosis, it'll help postnatal outcomes.
Well, you answered a lot of our questions that we had on this. No, that's great. That's great, because I tend to do the same thing. As someone asks me one question and I go down but this is good information. Let me back up a little bit. I guess the first thing you talked about, if 20 weeks rolls around. I think that's the standard time frame when somebody gets an ultrasound.
Mhm.
And so they're kind of doing that general ultrasound. So the OB is looking, and they might see, they're all at this point in time kind of, they're looking at the structure of the heart. They might see something there. When they're using at 20 weeks, maybe just to help us understand a bit better, is this a vaginal ultrasound being done at 20 weeks, or is it on the belly?
Yeah, usually the typical anatomy scan is done on the abdomen, so gel on the abdomen. And the typical anatomy scan will be looking at the fetal heart, the long bones, the brain. If you're doing like another level, a level 2 ultrasound, they'll be looking at kidneys and other things. As I mentioned, they're supposed to, if the fetus allows for it, there's certain views of the heart that they should be able to obtain. Usually the fetuses kind of rule the ultrasounds, and I'm sure our families out there know that by having to go back repeatedly. But there's certain views of the cardiac chambers, outflow tracts that they should be able to see. And if they saw something abnormal, or a lot of times we get referrals for, they're unable to get these images, then you'd be referred for a fetal echocardiogram. And the only difference is we just focus on the heart. So we're subspecialized in it. There's many other things we look at. We look at each of the valves. We're measuring all the valves, making sure they're appropriate in size for that gestational age. We're looking at the flow over the valves by using Doppler technology. So we can tell if there's any abnormal flow, a valve is leaking, or a valve looks narrow or stenotic to intervene on.
And actually, you just brought up kind of something we were touching on our pre-discussion a little bit, was looking at Dopplers and looking at those flows. And there's terminology that comes out about absent flow, or absent reverse flow, or reverse flow. And obviously those are serious things that give you indication that something's going on, but it can be very scary to a family hearing this. Can you briefly just kind of talk about, just in basics, because we hear those things a lot of times across a lot of different fetal syndromatic issues, what those mean?
Yeah, so when we're using Doppler, what that's doing is it's actually sampling the blood flow over something. So in cardiology, what we do is we look at the flow over a valve. So we're able to see if the flow is abnormal or not. And with color interrogation, when you see all the colors on ultrasound, what that tells us is the direction of flow in relation to our probe. So we can tell if a valve is too narrow, you actually can see that the flow over that valve is increased, or you can see if a valve is leaking or regurgitant or insufficient are the words we use, which is typically abnormal. In cardiology, when we see reversal of flow, specifically if we're looking at our aortic arch or ductal arch, that can tell us that there is critical congenital heart disease, specifically with either the aortic valve or pulmonary valve. And when we say reversal of flow, that means the flow is going in the wrong direction. So when I'm looking at an aortic arch, I should just see flow going over that aortic valve and through the arch. Now, if I'm seeing reversal flow, so it's coming backwards, what that indicates to me is that there's not enough flow going over that aortic valve. And in that case, it would be the case of the critical aortic stenosis, where we could potentially intervene if the fetus reached other criteria.
That's very helpful. And I think maybe to help us understand too, because you're looking at potential congenital defects with the heart taking place with that, with a situation like twin-to-twin transfusion syndrome, or TAPS or something like that. Sometimes we see those reverse flows, but that has to do more with kind of the blood volume, doesn't it? Than a congenital issue.
Yeah, so a lot of time, when they're talking about reversal of flow or absent diastolic flow, they're usually looking at the umbilical artery Dopplers, which are kind of assessment of the fetal well-being in another case. So in fetal cardiology, when we're talking about reversal of flow, it's flows going the wrong way in the vessels, which gives us a red flag that there's some form of congenital heart disease.
Gotcha. Okay, thank you for clearing that up. Yeah, because I know that's kind of that helps, because you're looking at specifically, but you can see reverse flow in different areas of depending upon where you're looking at it. So that's very helpful. So we have the OB, they find something, they refer to you, you look more into this, a type of thing. Now you have potentially, hopefully, some type of diagnosis of what's going on. At that point is some counseling with the family, I would assume, and then options. And obviously it's hard to say, what are some of the typical things you see, because we know there's a wide range of things that you can see. Like you said, there's could lead to, there's some thought that, if something's discovered long, it could prevent by doing this procedure, the hypoplastic left heart syndrome and things. So what type of things can be treated during pregnancy versus obviously right after pregnancy? And I think I want to stress the importance too, what you can explain all that too, is that having these type of things sometimes can feel like, okay, now I know this, but now what? Well, it's very important for the planning of the delivery, of when to deliver, and then what type of intervention might need to be needed right after delivery to obviously help support the baby and give them their best chance of less morbidity and mortality issues too.
Yeah. So I should clarify, we talked about how a lot of times fetal echocardiograms were referred for fetal echoes based on abnormal anatomy scans. However, there's a lot of other conditions that need fetal echocardiograms, even having a normal anatomy scan. So if you don't mind, I'd like to go into that and then go into a couple more of the details that we're talking about. Yeah. So, I would like to say congenital heart disease is the most prevalent of all fetal malformations. It's estimated that 1% of all babies born are born with some congenital heart defects. But there's some conditions that can increase that baseline risk. So, for example, women that have had assisted reproductive technology, whether that be in vitro fertilization or intrauterine insemination, that risk can go up to 3%. Any family member or families that have a first-degree family member with congenital heart disease, that can increase the risk of the fetus having congenital heart disease. And the risk increases depending on who that person is. So mothers with congenital heart disease themselves, the risk to their fetus is increased 3 to 7%. Depending on what the lesion mom has, that can increase even further. So moms that have atrioventricular septal defects, that can increase it to 10 to 14%. Moms that have aortic stenosis, that can go to 13 to 18%. Overall, fathers that have congenital heart disease, the risk is a little bit lower at 3 to 8%. And then siblings, full siblings will be 2 to 6%. There's also, independent of having a normal anatomy scan, moms that have gestational or pre-gestational diabetes, so type 1 diabetes, they're at a 3 to 5% increased risk of congenital heart disease. And the relative risk for specific lesions is even higher. So for heterotaxy, it's 6. For single ventricle defects, it's 18. So any mom that has type 1 or pre-gestational diabetes should get a fetal echocardiogram independent of their anatomy scan. There's also type 2 or gestational diabetes. I only mentioned this because this is unfortunately very prevalent in our community right now. The risk of congenital heart disease is associated with how high their hemoglobin A1C is. So the higher your hemoglobin A1C is, the more likely your fetus is to have congenital heart disease. Wow. And in addition to fetal congenital heart disease, the elevated sugars can not only alter the structure of the heart, but over time, it can actually make the muscle thicker. So it actually can block the blood flow out of the heart. So if the sugars aren't well controlled, this can also develop during the pregnancy. Also, moms that have certain autoimmune diseases, so like lupus or any mom that has SSA antibodies, like in Sjogren's syndrome, 1 to 5% of those fetuses are actually at an increased risk of developing something called congenital heart block, and that will lead to a bradycardia or a slow heart rate in the fetus, and it can lead to high drops. So we actually monitor those moms every 2 weeks, starting at 16 weeks to up to 26 to 28 weeks, when that's the major risk of the antibodies attacking the electrical system. And if we see that there's any evidence that the slow heart rate is forming or a heart block is occurring, we can actually start treating mom for that. So that's one of the things that we can treat mom during her pregnancy to help prevent. There's also maternal medications if mom is taking medications at the time of conception or during pregnancy. So certain anti-epileptics like carbamazepine or angiotensin converting enzyme inhibitors, which a lot of moms that have cardiac issues are on, or moms that are on retin A, all of that can increase the risk of congenital heart disease. And then usually these fetuses come to us, but any fetus with extracardiac congenital malformations. So if there's more than one extracardiac congenital malformation, that will increase the risk of having a cardiac defect 20 to 45%. Babies that have omphalocele, it'll go up to 30%. Duodenal atresia is 20%. Any GU abnormalities can be up to 70%. And then another thing in our community that's gone up is the number of twins. So any twins that have are monochorionic or sharing a placenta, the risk of congenital heart disease can go up to 2 to 9%. So based on those individuals should come to us, and we can help intervene, as you mentioned, on certain lesions. So there's certain congenital heart disease lesions. So critical aortic stenosis, any fetus that has hypoplastic left heart with a restrictive or intact atrial septum, those are the ones we really offer fetal cardiac interventions on. Fetuses that have arrhythmias, so whether that be a bradycardia with a low heart rate or a tachycardia with a high heart rate, we really need to intervene on those babies or fetuses because they can develop hydrops, which, as the audience may know, is fluid collections in multiple compartments. Whether that's giving mom a medicine to help slow the heart rate in the cases of a supraventricular tachycardia, or giving moms, in the case of lupus, like steroids that can help the inflammation happening in that electrical system to help prevent the development of congenital heart block. Those are like the major ones we can intervene on for twins, as you've mentioned earlier, with our monochorionic diamniotic twins sharing a placenta, 2 sacs. They're at an increased risk of twin-twin transfusion syndrome. In addition to 2 to 9% of them having congenital heart disease, they're actually at a risk, if they develop twin-twin transfusion syndrome, for the recipient to actually develop congestive heart failure because they're just getting so much more fluid. And then we've also seen that they develop right ventricular outflow tracts or pulmonary stenosis. And we know if we intervene on this through laser, it can actually improve over time. So those are just a few of the fetal lesions or cardiac issues that we can help intervene on during pregnancy.
Well, that's amazing. I mean, first of all, it's just kind of amazing of all the stuff that you can actually do to intervene and give the babies the best chance. We have some couple of kind of questions that come into me too, because I think just, for people that may not understand, once, obviously I'll let you answer this question. I know the answer to this, but just because people don't understand, is getting an echocardiogram during pregnancy, is there any risk associated with it?
No, the good thing about ultrasound is it doesn't put the baby or the fetus at any increased risk. It's just like getting your normal ultrasound. So there's no risk to the baby. I guess the biggest risk is getting a rash to the gel, but that's about it.
And then currently, is there any standard? I mean, I guess it depends if there's anything found on anything like that, but how often do you have to go? You have to give just one, or is it many? Obviously, if the OPC is something, they've done one thing, just kind of going up to other levels. But what kind of happens if something is found?
So, when it comes to a fetal echocardiogram, let's say it's in the scenario where it is something abnormal that they saw in their anatomy scan. So then you get a fetal echocardiogram, and right away, one of the fetal cardiologists will go ahead and go for the results. If it's one of those cases, a lot of times we get referrals because they can't see those views that they would like to see, or there's something that's a little off. Hopefully it's those cases where, everything measures out normal. And then once you see the fetal cardiologist, we usually say, your baby's fine, just needs typical postnatal care. If it is one of those cases where it's congenital heart disease, it really depends on the type of congenital heart disease we're seeing. There's some babies that we see with small little holes in their heart, either in the top or bottom part of the heart, that will say, you don't really need another fetal echocardiogram. What we'll do is check on the baby after they're born to see, has it closed or not, because it wouldn't necessarily change postnatal management. Also, if we repeated the echo, let's say in the 3rd trimester, and baby is just in a bad position and there's lots of shadowing because of the calcification of the ribs, we'd still perform the postnatal echocardiogram. So to save mom and dad and family all that stress of another appointment, we would say we just check postnatally. For our babies that have critical congenital heart disease, and what that is it's a heart defect that needs some sort of intervention, whether that be a cardiac catheterization or some surgery within the 1st year of life, we usually have those families see us again at least one more time. And that second appointment is for multiple reasons. It's to reevaluate the heart defect and see the evolution of the heart disease, but also to re-counsel families. We know when we tell you your baby has congenital heart disease, it's very upsetting. And I know that a lot of the information isn't absorbed. We give our information. We want the families to reach out to us with any questions, but we know a lot of families don't feel comfortable with that. So with our second appointment and our repeat fetal echocardiogram, it's to basically go over everything again, to talk about the prognosis of the defect, but also to meet the new team that'll be following you and your little one throughout their life. So here at UC Davis, what we do is you'd meet with the fetal cardiologist. If it was one of those critical congenital heart diseases that would need some sort of intervention, you would meet with our pediatric cardiothoracic surgeons. You would meet with our maternal fetal medicine doctor who would help coordinate delivery, because we see a lot of families from around California. You would also meet with our neonatologist who would talk about postnatal care in our neonatal ICU. You would meet with our fetal cardiology, our pediatric cardiology nursing team who would help with that transition to postnatal cardiac care. We also have multiple other services. You can meet with our social worker. You can meet with several other providers or interventionalists if there's other extra cardiac malformations too. So that's the point usually for that second meeting, but usually depending on the heart lesion, it's the diagnosis. If it's critical congenital heart disease, we'd see you at least one more time at our institution. There's other institutions that see families more regularly, but we know it's interrupting to families' lives.
Yeah, well, and I think one of the things I love kind of hearing about, and I think it's important for people to realize, is that you talked about all the different specialties that need to be involved in the care at times, and it's really great because if they can all be working together, it seems scary because you're like, okay, now I've got another specialist I'm meeting with and going through this, but if they can all be working together, and that makes everything so much better for the outcomes and the plan of care, as opposed to being disassociated and trying to get in touch with and relay information. So that's very comforting, and that is an area that we've seen in the last decade, and even keeps improving, of that interdisciplinary care taking place. I was going to ask you, you mentioned that some of the stats about different things that might have a higher increase for type of congenital type of situation. If I'm, obviously sometimes I would say, I think from this is also very important. Make sure that you go over your complete medical history with your doctor, your OB, so that they can best guide you on that. But certainly, let's pretend everyone's human, and sometimes, unfortunately, I'm going to be blunt about there are some really fantastic OBs, and sometimes there's not.
Yep.
And if I have these conditions and I'm worried about, hey, my doctor never said anything or didn't really think it was a problem, should I reach out to somebody as like yourself and see about getting a second opinion?
Yes, please do. I think, part of my job coming here was to really go out into the community and talk to a lot of OB providers to be like, even if the anatomy scan is normal, these moms need a fetal echocardiogram because of that increased risk. And because we know on anatomy scans, they may not be able to see all the views. So if you know, or you suspect you should be getting a fetal echocardiogram and your OB hasn't necessarily mentioned it, feel free to reach out to us. I'm happy to answer any questions. I'm always attached to my computer and phone. You can always email us at UC Davis. We're at fctc@ucdavis.edu. Please feel free to reach out. Me or my colleagues can happily talk to you, and also tell you about centers in your area that would be happy to provide fetal echocardiograms.
Oh, that's great to hear. And I'd like to, offer that out there too, is, reach out to Fetal Health too, if you need. We have such a great relationship with our partners. And a lot of times I always feel like I've got the red phone in to them so I can quickly help get in contact, because I think it can be intimidating sometimes for families, because you are at such a high specialty in what you do, that it can get intimidating of, you are, like you said, you're attached to your computer and phone, you're there to be a resource and help people. But a lot of times it can feel intimidating to reach out to you because you are highly specialized in what you do. And we want to take that away, because I've found it completely the opposite. We know, we've been, as Fetal Health, and have had been working with so many of wonderful caregivers in the medical side of things that I've heard of stories and been told of stories where they're worried about a patient and they're at midnight and they're at home trying to sleep and they can't figure something out and they're trying to come up with ideas and ways to help. So I as much as sometimes you might feel like when you walk into a clinical situation, it can feel sometimes cold, it can feel sometimes intimidating, but really those of you like Dr. Sundergi and others are really there to help you out. And they really are caring, and they really are very compassionate, and they want to help you have a successful pregnancy and have an outcome and be able to provide the care that's needed for the baby or babies, depending upon what the situation. And I think you mentioned, I just want to bring this out. You said it's in the United States, or I guess maybe it's probably worldwide, but on average, it's 1% of babies born have some type of congenital heart defect.
Yeah, it's 1%. It's estimated at about 1% of all live births. The incidence is actually higher, but some of those fetuses don't make it when they have the more severe congenital heart disease.
Are there, maybe this is a question I'm just thinking, well, gosh, there's a lot of things, we hear that can go wrong. Are there things that as in family planning, which sometimes oops, didn't plan on having a family or didn't plan on getting pregnant, but is that like, obviously the medications you could be on, it's important to know what the effects could have on a fetus and those type of things. Are there things just in general when you're pregnant for the everyday person that they should or should not be doing to ensure that they have a successful pregnancy, or that doesn't lead to potential heart complications or congenital defects?
Yeah. So you touched on the major one that people can actually have control over is the medications they're on. So if you find out you're pregnant and you're on medicines, feel free to reach out to your obstetric provider. And there's medications that are fetally safe that we can change or transition moms to. That's the one that is the most controllable. Also obviously, exposure to illicit substances. Some of them are associated with increased risk of congenital heart disease. So if you can stop that, that's helpful. But otherwise, it's mostly taking good care of yourself. Unfortunately, we haven't figured out the specific genes for each of these congenital heart lesions or any other active therapies we can do to prevent the formation of congenital heart disease. But mostly what we recommend is taking care of yourself, making sure your medications are safe for you and fetus.
Yeah, and I think you hit something on that makes me think of a doctor that was in Colorado that used to study a lot on intrauterine growth restrictions. And I remember talking with him because a lot of times people think, well, my baby's not growing, so I just need to eat more. I need to do this and do these different things. And that's not necessarily the case. But one of the things that I thought was interesting, and you just kind of hinted at this a bit, is just, take care of yourself. And I think oftentimes, or at least sometimes maybe it's not so much as it used to be, but it used to be like, you're pregnant. So it's like you're a medical condition and you shouldn't be doing anything and you should be just resting and doing all these things. But really, as long as it's safe, be active, stay healthy. Think about more so than ever. I mean, unfortunately, in America, we're really bad with our diets. But this is a good time to make those changes, because all that plays a factor of, I always like to say that if you're giving your body really good nutrients, and it doesn't mean you can't, have your ice cream and other type of things too, but all in moderation, but providing really good quality nutrients into the body is only going to help nourish the baby in the long run and make you healthier and stuff. If you're not feeling good, there's a good chance your baby's not feeling good too, because I think it was described to me as that you have to remember the baby's going to take what it needs from you first. You get the leftovers. So if you're not feeling very good and you're feeling tired and things that maybe seem out of whack, it's not a bad idea to talk to your medical care professionals and make sure everything's going okay, but also look at what you're, how, again, be healthy.
Yep.
Awesome. Well, great. This has been so informative, and I thank you so much on this. I know we have a video we want to go into and watch a bit too that you shared with. Is there anything else that I didn't cover that you want to make sure that we share?
No, it's really for the families out there. It's just like you said, please reach out to us. We understand, a lot of us are parents ourselves. We understand the stress of pregnancy. We understand when a test doesn't come back normal, the stress that puts on families. So if you have any questions, feel free to reach out. There's a lot of resources out there, like the Fetal Health Foundation. There's also For fetal cardiac issues, there's a Fetal Heart Society. There's NAFNet, which is the North American Fetal Therapy Network. If you're looking for certain studies that are going on, you can reach us at, I said, fctc@ucdavis.edu. Also Fetal Care at ucdavis.edu. We have a lot of information on there. Feel free to peruse it. And please reach out to your providers. We are here to help and are happy to answer any questions.
Wonderful.
When I first got the news about Zane, I was very emotional because I've never heard of spina bifida. At the time, I just turned 19, and we've never heard of in utero fetal surgery at all. So when they brought it up, I had to have them really elaborate on it. And I was like, how is this possible? At first, it was super hard to accept, but with Hiroshi being so confident in his team and meeting everybody in UC Davis, that's what made me continue forward.
Hi.
Hi.
I'm Dr. Hiroshi.
I'm Taylor.
Dr. Hiroshi, he answers every question. When he's with you, he is present. Found out I was pregnant. Surprise.
Twins.
Yeah. So we found out it was twins. I had a local doctor in Chico. He was fully aware of twin-to-twin transfusion syndrome. So after we had this specialized ultrasound, the doctor in Sacramento referred us to UC Davis Medical Center and Dr. Hiroshi's team at the Fetal Care and Treatment Center. I had a consult with Dr. Hiroshi, and he asked if he could admit me immediately. He knew that Quinn's twin sister probably wasn't going to make it through the surgery because she was so sick. And he was very gently clear with us, telling us that.
UC Davis and the Fetal Care Treatment Center really make the process so much easier to get through. Savannah and I came in and got an ultrasound, and at that time is when we found out that she has a heart tumor, and she also had really bad high drops. We were told it was probably about a 5% chance that she was gonna make it, but that I did have options, that Dr. Sundergi was so compassionate and let me know that there's still hope and not to give up on that hope. And that's exactly what I did.
Raina had open heart surgery on her AV canal defect. Because of her heart defect, about half of those kids are born with Down syndrome. And Dr. Sundergi was so comforting in this moment. We're so grateful that we had her in our corner and that it was her that was Raina's cardiologist, specifically. Because I don't know what I would have done, I think. It was so scary, but yeah.
If I were to talk to any other parents that got the news of the spina bifida, I would tell them to go to UC Davis and meet with my fetal team and just talk about your options. Zane now is a very energetic 3-year-old. You don't notice his delays. I love when he wakes me up. Most parents don't say they like their 3-year-old barging in their room, but I'm proud to say my kid can run into my room, open my doors, and jump in my bed and be like, "Hey, Mom, it's time to wake up."
Never give up hope. Things can be okay still. Savannah does still have heart problems. She's doing so great considering everything that she went through and is still going through.
I wouldn't trade the journey for anything. Raina is sassy, for sure. She's super funny, super fiery. She can't just sit still.
Quinn, you wouldn't know it to meet her that she had such a rough start and how close we were. I mean, everything happened when it was supposed to happen, and she's here because of it. This team absolutely has everything dialed in. Their patients are absolutely number one. I can't imagine any place else would do as good a job.
They're amazing.
Mm-hmm.
They're part of the family. They're the real deal. They're the real deal.
You're my favorite toaster.
See you when your name was coming up and some of the patients that you treated, I could see the emotion on your face. And I think that's a real testament to how much you really do care.
Those patients have special places in my heart. So Yeah, I think we as providers are so honored to be a part of families' journeys. So I really want to hopefully break down that barrier between families reaching out to us. So whatever you guys need, we're here to help.
No, I appreciate that. And honestly, like, thank you for all that you do, because I know it's a lot of work. It's a lot of a sacrifice to do what you do. It's from being having gone through a fetal syndrome with my own daughters to all those that are going to do that. We can't thank you guys enough for that. We've had the pleasure of working with Dr. Farmer, who I know you're all too well of, in the work that she's been doing for many decades, and just continually to never give up the fight on trying to find ways to help somebody during a pregnancy when there's a situation. And I like to say that, we're always, for fetal health and stuff, we're always about giving families the best resources available and letting them get all the facts so that they can make the best decisions that's right for their family. Sometimes, unfortunately, there's some tough decisions that have to be made, but we never want a family to have to come back and say, had I only known. And the fact that, when you are planning a family, excited about a family, excited about thinking about the first steps and the first smile and the first diaper changing, which scared me to death because having twins was like, there's two. But thinking on all that is to have a diagnosis come across, and it kind of ripped away all those dreams, and everything becomes. So that's the moment you become a parent real quickly to the baby or babies in that situation. You're trying to do everything you can to understand what's going on and try to help them have hopefully a happy, normal life. And so thank you on behalf of all patients and all those that you have yet to come in contact with. We're very thankful for you.
Well, thank you.
We want to, again, could you repeat the address of how the website address of how people would find you guys?
Yeah, definitely. It's fetalcare.ucdavis.edu. And if you would like to email me or any of our fetal interventionists, it's fctc@ucdavis.edu.
Thank you so much for that. And we'll be putting that information on our thread. And then when we edit all this together, make it look pretty so it lives out there forever, we will also try to get that information out there. So Dr. Sundergi, thank you so much. It was a pleasure meeting you. Thank you so much for being part of this with us today and giving us all this important information and making it, giving people information about the importance of a fetal echocardiogram, what's being looked at, what type of things can be done if something's found, and generally just to get people an understanding of why they're used. So we thank you very much for that.
Oh, thank you for the opportunity, Lonnie. It was nice to meet you.
Well, thank you, everybody. This has been Lonnie Somers with the Fetal Health Foundation and our Fetal Care Chat. We hope you have a wonderful day. Thank you.